Good day. We're the Block Z interns of the Philippine General Hospital, and we're here to present a short lecture about Preprom, or Preterm Prelabor Rupture of Membranes. Preterm Prelabor Rupture of Membranes, or Preprom, and Prelabor Rupture of Membranes, or PROM, as their name implies, both refer to the rupture of membranes before the onset of labor. However, we qualify PROM as PPROM when the rupture of membranes occur before 37 weeks age of gestation. Furthermore, we can classify PPROM based on the weeks of gestation of when it occurs. We call it previable premature rupture of membranes if it happens at less than 23 weeks, PPROM remote from term if it happens at 24 to 32 weeks, and PPROM near term if it happens at 33 to 38 weeks age of gestation. Depending on the age of gestation, different management options may be applicable for the patient. In general, PPROM is associated with 30 to 40% of preterm deliveries and is the leading cause of preterm delivery, complicating 3% of all pregnancies. These incidences can be explained by a wide array of mechanisms, but are generally caused by the weakening of the membranes combined with forces produced by uterine pressure. Among these mechanisms, an intraamniotic infection is commonly associated with PPROM, as the ascending bacteria secretes collagenases, which weakens the fetal membrane. Consequently, the response of the pregnant woman's immune system to increase her host cytokines, and the resulting imbalance between matrix metalloproteinases and tissue inhibitors of metalloproteinases from the microbial colonization also contributes to fetal membrane weakening. Some specific pathogens associated with PPROM includes Neisseria gonorrhoeae, Chlamydia trachomatis, Trichomonas vaginalis, and Group B streptococcus. Other causes of fetal membrane weakening include prior preterm birth, polymorphisms of specific inflammatory proteins, and connective tissue disorders such as the Ehlers-Danlos syndrome. However, despite the variety of etiologies, often there is no obvious cause that is identified in a patient who presents with PPROM. Aside from these mechanisms, other risk factors that might predispose a pregnant woman to PPROM includes a low socioeconomic status, smoking, history of sexually transmitted infections, previous preterm births, uterine overdistension, presence of vaginal bleeding, and a history of cerclage or amnioinfusion. In most instances, PPROM is readily diagnosed by history, physical findings, and simple laboratory tests. A history of a large gush of clear vaginal fluid, or a steady or intermittent leaking of fluid from the vagina, along with a speculum examination showing the pooling of amniotic fluid in the posterior vaginal vault, highly suggests premature rupture of membranes. However, take note to avoid doing digital vaginal examinations when suspecting PPROM. Moreover, there are additional tests that we can do to confirm PPROM. An ultrasound examination demonstrating an amniotic fluid index of less than 5 centimeters suggests Oligohydramnios, although a documented Oligohydramnios alone is not diagnostic of rupture of membranes. A markedly reduced fluid volume in the presence of normal fetal kidneys and the absence of intrauterine growth restriction is highly suggestive of ruptured membranes. Aside from imaging, other standard tests to confirm PPROM include the determination of alkaline pH through the nitrazine test, and although not recommended anymore but is still useful in low-resource settings, the litmus paper pH test may be utilized. In both tests, strips will turn blue if the pH is greater than 6.0. A blue strip means it is more likely that the membranes have ruptured. In addition, the detection of a ferning pattern in the fluid discharge, once viewed under the microscope, is also a suggestive measure. The characteristic Ferning highly indicates a leaking amniotic fluid. Newer options for detection of ruptured membranes are also available in the market. These include absorbent pad or sac-secure amniotic fluid detectors, a panty liner-like material which detects leaking amniotic fluid and identifies the cause of wetness during pregnancy. From orange, it will turn blue if stained with amniotic fluid. The next is fetal fibronectin. These are glycoproteins responsible for the adhesion of the placenta to the decidua. They are released after damage to the membrane and are detectable in the amniotic fluid. Another new option is testing of placental A microglobulin protein 1 or PAMG1. Akin to fetal fibronectin, these are glycoproteins in the amniotic fluid that should not be found in cervico-vaginal secretions. It is one of the most sensitive tests for amniotic fluid leakage. Lastly, insulin-like growth factor binding protein 1 may also be utilized as it imposes a high index of specificity and sensitivity. It is prudent to properly confirm the diagnosis of PPROM as there are various complications associated with it, which can potentially affect both mother and her fetus. For the mother, there are complications in the antepartum, intrapartum, and postpartum periods. Of considerable concern and morbidity are infections that can result in intraamniotic infections and chorioamnionitis. For the fetus, effects of PPROM depend on the gestational age when the rupture of membranes has occurred. For any age of gestation, prematurity and its associated problems predominate. These include respiratory distress syndrome, neonatal sepsis, pulmonary hypoplasia, necrotizing enterocolitis, intraventricular hemorrhage, cerebral palsy, and other developmental delays. Aside from these, there may be stillbirths, especially for previable premature rupture of membranes. Perinatal infections and cord compression may also result in non-reassuring fetal status and a more expedited delivery. In managing a patient with PPROM, a multimodal approach is employed. This includes IV empiric antibiotics, antenatal corticosteroids for the fetus, judicious use of tocolytics, and appropriate timing of labor and delivery. There are multiple benefits of antibiotic administration. It reduces risk of clinical and subclinical maternal and fetal infections. It prolongs the latency period and allows the administration of corticosteroids. And it improves perinatal outcomes by delaying delivery due to preterm labor. The standard regimen is ampicillin 2 grams administered intravenously every 6 hours, plus gentamicin 1.5 milligrams per kilogram every 8 hours. Alternative regimens are ampicillin sulbactam 1.5 to 3 grams intravenously every 6 hours, followed by oral ampicillin sulbactam 750 milligrams twice a day, or cefoxitin 2 grams intravenously every 6 hours. Clindamycin 900 milligrams intravenously every 8 hours after cord clamping, or metronidazole 500 milligrams every 8 hours may be added for anaerobic and enterococci coverage, respectively. Because PPROM is associated with preterm labor, all fetuses between 24 and 34 weeks threatened with premature delivery are candidates for treatment with antenatal corticosteroids. Benefits of antenatal steroids are multiple and include reduced neonatal mortality and incidence of respiratory distress syndrome, significant reduction in the incidence of intraventricular hemorrhage, improvement in the circulatory stability and reduction in the requirements of oxygen and ventilatory support, and a reduction in neonatal hyperbilirubinemia. The current standard of care includes the use of either betamethasone 12 mg intramuscularly given for 2 doses 24 hours apart, or dexamethasone 6 mg intramuscularly given for 4 doses 12 hours apart. Tocolytics should not be used routinely. Rather, it should be considered only when a clear clinical benefit exists, such as the transport of the mother to a tertiary institution with a neonatal intensive care unit. Because there are no clear data to support a first-line medication, the choice of a tocolytic agent should be individualized depending on the maternal condition, potential side effects, and the age of gestation. All classes of tocolytics listed result in the suppression of uterine contractions by acting on various ion channels, receptors, and enzymes. Medical practitioners should also be aware of their dosing and potential adverse effects. Most current data seem to favor calcium channel blockers, such as nifedipine, as a tocolytic agent of choice due to its more acceptable side effect profile. It is usually given as a 30 mg loading dose and then 10 to 20 mg every 4 to 6 hours. Beta-adrenergic agents, especially terbutaline, is one of the more popular tocolytics. It may be started intravenously at 5 to 10 micrograms per minute, then increased every 20 minutes by 5 to 10 micrograms per minute to a peak rate of 25 micrograms per minute. It may also be administered subcutaneously at 0.25 milligrams or orally at 5 milligrams every 24 hours to deliver a daily total dose of 30 milligrams. Magnesium sulfate, although particularly useful in women with preeclampsia or eclampsia, cannot be recommended as a primary tocolytic agent for labor in PPROM because currently available evidence shows that it is ineffective at delaying preterm birth. Caveats of using magnesium include using recommended doses, monitoring urine output, deep tendon reflexes, and respiratory rate during infusion, and having calcium gluconate available at bedside. Other tocolytics include COX-2 inhibitors, progesterone, and oxytocin receptor antagonists. However, the evidence supporting their use is less robust. How about the timing of delivery? The primary indicator for the need to deliver as soon as possible is maternal health. Any evidence of intrauterine infection or maternal instability due to complications of PPROM, such as bleeding, abruptio placenta, or fetal distress, requires careful evaluation and determination if aggressive management is warranted. Age of gestation can also influence our management strategy. If PPROM occurs after 36 weeks age of gestation, expectant management may be justified initially because up to 75 to 85% of women with PPROM will enter labor in the next 24 hours. This should be balanced against the increasing risk of maternal or neonatal infections as delivery is further delayed. If PPROM occurs at 34 to 36 weeks age of gestation, most guidelines favor the induction of labor. Aggressive management is indicated if there is evidence of intrauterine infection, abruptio placenta, or fetal distress. If PPROM occurs at 31 to 33 weeks age of gestation, expectant management, Group B streptococci prophylaxis, and single-course corticosteroids may be given. Antimicrobials may be given if without any other contraindications. In contrast, for PPROM at 24 to 31 weeks age of gestation, expectant management is the most favored option. Antibiotics may be given if without contraindications, and the risk versus benefits for tocolysis is determined. Steroid use is individualized for PPROM at 24 to 31 weeks age of gestation. Lastly, for PPROM earlier than 24 weeks age of gestation, the most appropriate management is not clear and must be individualized. Patient counseling is paramount as very preterm babies have lower survival and more morbidity from prematurity. For the mode of delivery, a vaginal delivery is still preferred. The indications for a cesarean section delivery do not differ and are still based on standard obstetric indications. To summarize, PPROM is defined as the rupture of fetal membranes before the onset of labor, before 37 weeks age of gestation. It is highly associated with preterm births. Diagnosis is confirmed via good history taking, sterile speculum examination, nitrazine test, Ferning test, fetal fibronectin tests, and ultrasonography. It is important to remember that an internal vaginal examination should be avoided. Finally, management is individualized and may involve the use of antibiotics, antenatal corticosteroids, judicious use of tocolytics, frequent monitoring for fetal maternal complications, and appropriate timing and mode of delivery.